Okay. So, good afternoon, everyone. Continuing with the topics of sepsis.
This meeting is being recorded.
So yesterday we finished about patterns of resistance in MDR sepsis. So we are going to look today at management of MDR GNVs. Okay. So in the question, if an exam paper comes, they might ask you things like, how do you manage an MDR GNV? What are the resistant patterns that you see in MDR GNV? What is synergy testing? I'm sorry for the typo. Okay. So these are the questions that can be asked pertaining to specific concepts of sepsis related to MDR. Okay, coming to MDR gram-negative bacilli, before understanding how do we treat them, we'll know what are they. Okay, so they are ESBLs, that is your enterobacterials, which are having resistance because they hydrolyze third generation cephalosporins. Okay, they are categorized usually as class A amblers, and they have enzymes like Temanara, SHV, CTXM families. Okay, this is one group of MDR GNB. The second one is your CREs, the carbapenem resistant enterobacterials, because of production of carbapenemases. Okay, again they can be ranging from class A to class D. Okay, except class C. Okay, sometimes they can be mixture of ESBL AMC as well. So they all come under the category of CREs. Okay, whenever there is a carbapenemase present, then they'll be categorized as carbapenemase producing organism, or CRE, carbapenem resistant enterobacterials. The next one is carbapenem resistant Acinetobacter baumannii. Okay, you might be asking, we have already told you earlier about CREs, etc. Why do we have to specify a separate organism like this? I'll be dealing with this in the subsequent slides. Okay, so after this, there is difficult to treat Pseudomonas aeruginosa and Stenotrophomonas maltophilia. Okay, majorly whenever you look at your IDSA guidelines, etc., no, they deal with crab organisms, Pseudomonas, Stenotrophomonas, ESBLs majorly, and CRE. Okay, these are the group of organisms that the primary focus lies on when we are managing MDR sepsis, even in the ICU, especially in Indian scenarios. So how do we classify MDR gram-negative bacilli? They can be based on four major ways. Okay, either by spectrum of resistance that they develop, mechanism of resistance they have, clinical pathogens like how we get our report from the labs, or by WHO priority. Okay, so probably in your viva they might ask you what is WHO priority pathogen list. Okay, if you remember the critical pathogens, it's more than enough. I'll be discussing each one in detail. Okay, so when we're classifying MDR GNVs by spectrum of resistance, okay, so we all know this, it's very straightforward: MDR, XDR, and PDR. We know MDR is non-susceptibility to three classes of antimicrobials. In XDR, they're susceptible only to one or two categories. In PDR, they are not susceptible to all agents. Okay, so this is by spectrum of resistance. It's similar for both. It can be GPC or GNB. Other one is mechanism of resistance. Like I told you yesterday, it can be hydrolases, ponin pumps, efflux mechanisms, target site alterations, or intrinsic resistance. Okay, so this is by mechanism of resistance. Then comes clinical pathogens. So usually the first two ways, uh, probably the mechanism of resistance we will not get straight away. Okay, sometimes we have to deduct it by the report which we get, and most of the times the uh, AMST report which we get, right, the report usually will tell us what is the organism. Sometimes they broadly would classify it as non-fermenters unless they give us the final report, because when you get an interim report, they will usually mention it as enterobacterials or non-fermenters. Then we'll get a complete report, right? Along with it, some labs also give us the sensitivity at the same time, by which we can come to an understanding whether this patient is having an MDR sepsis, XDR sepsis, or PDR type of sepsis. Okay, so again, when we have clinical pathogens, especially by based on the reporting which we routinely get, we have ESBLE, that is your Klebsiella pneumonia enterobacters, or your CREs like KPC and demoxa producing organisms, that is your E. coli. Okay, again, non-fermenters can be Pseudomonas, Acinetobacter, Stenotrophomonas, and Burkholderia. Okay, of lately we are seeing all these organisms becoming quite commonly seen in the culture sensitivity report, majorly because of inadvertent use of antibiotics and probably because of increasing resistance. Okay, so coming to the last type of classification, this is the WHO priority pathogen. If you remember this, well and good, but this is a take home or a brownie point only for your practicals. Okay, so remember the critical priority. This list was actually released long ago in 2017 when we started noticing that most of the antibiotic pipeline is getting dried up. Okay, at the same time, they told that these organisms are the ones which require newer antibiotics at the earliest. And the critical priority is the priority to find new antibiotics. And unfortunately, we have not achieved that even in 2024. And that's the reason WHO reaffirmed that these three organisms, that is, carbapenem resistant Acinetobacter baumannii, carbapenem resistant Pseudomonas aeruginosa, and the enterobacterials all form under a critical priority list wherein these type of sepsis would be detrimental and will carry a higher mortality rate. Okay, so other groups, if you remember high priority, medium priority, need not remember, but just remember crabs, pseudomonas, okay, and CREs, they usually fall under the high priority or critical priority list of the WHO classification. Okay, so this is the way we classify about MDR GNBs. Okay, so you remember the, if you just remember it as ESBLs, CRE, carbapenem resistant Pseudomonas, okay, along with Stenotrophomonas, that should, and carbapenem resistant Acinetobacter baumannii. Okay, if you remember these five, that should be enough. If you write this also, it's good enough. Then you can write routinely how you write for your patterns of resistance. So that will help you gain few marks. Okay, just if at all it is asked as a 10-mark question. So coming to the next part of it. So if at all they ask you, how do you manage this? So questions can be, how do you manage a case of CRE? Okay, if it is carbapenem resistant enterobacteriaceae, first you will tell this is what you're suspecting. These are the group of organisms like E. coli, etc. After that, you'll go to the examination. In examination, you will tell that okay, we'll identify the source, etc., and then you will send in cultures. So what do you do for detection of resistance? Primarily, the first and foremost thing that we do is routine antimicrobial testing. Okay, sensitivity, AST, that is your antimicrobial sensitivity testing. That is your routine micro labs which you do. Okay, so with this, it can be a disk technique or any other technique that your lab usually follows. Okay, and then we will get a preliminary report which will tell us whether this bacteria has a susceptibility or resistance to that particular antibiotic. Okay, that will usually be based on CLSI or UCAS breakpoints, like I mentioned earlier. Okay, that is the first step in detection of resistance. Okay, so first step, once you find this out that there is resistance to one of the carbapenems, then you go ahead for the next one. Okay, so whenever we see for carbapenem resistance, okay, always look for resistance to meropenem and ertapenem. Okay, if at all they say imipenem sensitive, meropenem resistant, there itself you should get a little, steady and see that this patient has already developed a carbapenem resistant organism. Okay, so I told you yesterday about imipenem resistant, meropenem sensitive. All of this is a combination, usually because of carbapenemases which are present in that particular bacteria. Okay, so there will be a possibility where one carbapenem will be sensitive, the other would be resistant. Okay, it all basically depends on what is the resistance pattern in that particular bacteria. Once you know that there is a resistance, the next step is to know what type of resistance it is. That is where all your OXA48, NDM, etc., and all your other tests like CARBAR-SA, all of them come. Okay, so you need to do a phenotypic assessment and a molecular testing. Okay, sometimes you can also do advanced techniques like Malditoff. Malditoff, mind you, it is again a phenotypic detection technique. Along with that, there is something called as WGS, that is whole genome sequencing. It's very easy to tell this in theory, okay, but practically these are not routinely available. But for exam point of view, remember this. Okay, first you have to do your routine testing. Okay, you have, if at all your lab has a proteomic Malditoff, it is good enough. Okay, so you do that, then find out whether there is a resistance pattern which is present. Then you send in for molecular testing, and then based on the molecular testing you can narrow down as to what is the resistance pattern, and then you can choose your treatment regimen. Okay. Along with this, remember nowadays we are having something called as whole genome sequencing that will help us understand more resistance patterns. Okay. So getting the resistance pattern is not important. The problem is to treat them. Okay. So that is the whole underlining statement for uh, resistant organism management. That is your MDR or XDR or a PDR. Coming to general principles in management, I told you earlier, okay, you have to write this also in your theory paper. Write about source control, start the patient on empiric antibiotic therapy as much as you know based on your local antibiogram. Please don't forget to use terms like this in your paper, okay? This is what they're focusing on, okay? Source control and empiric antimicrobial therapy based on local antibiogram. Okay, these are the words you need to write now. And then you should also talk about optimizing based on PKPD principles. Sometimes you can talk about infusions, especially when you're talking about beta lactam therapies. Okay, so and the use of therapeutic drug monitoring for drugs like vancomycin, etc. Okay, so if you write all of this, you'll probably get some more points wherein you have a structured approach to that particular patient. Then once you get your culture sensitivity report and your resistance pattern, then you can talk about targeted therapy. You can talk about combination therapy or the use of newer antimicrobials. Okay, so what the current 2024 IDSA says is whenever we have an MDR bug in the ICU, especially if it is one of the priority pathogens or the critical pathogens which I mentioned earlier, they need to be reviewed by an ID specialist. Okay, and with this review, we need to come to an understanding as what the next choice of antimicrobial therapy would be. This constitutes firstly antimicrobial stewardship. Secondly, we will understand there will be a person who has sound knowledge in treating such cases, wherein optimal removal of this organism can be achieved. Okay, otherwise probably there will be treatment failure. Okay, so this is one place that you need to focus on when they ask you a question about management of MDR GNB. Coming to the approach of individual organisms. Okay, till now it was all a generalized way. Okay, so you need to write this part for any organism they ask. If at all they ask you CRE, crab, anything, you can write it or pseudomonas also, you can write all these things. Then you need to write per se what will you do for that particular organism, starting with ESBL enterobacterials. Okay, the first line, especially in a patient with severe infection, is always carbapenems. Okay, especially if it is an invasive ESBL infection. It is proven by Merino trial. Again, Merino was a trial which was checked to see what happens in bloodstream infections when we give piptaz versus meropenem. Okay, what it showed was piperacillin tazobactam was non-inferior to meropenem, but the take-home point from that trial was if it is a severe ESBL infection in the bloodstream, always prefer carbapenem over BLBLI, that is your pip test. Okay, then what it also said is IDSA says that if it is a non-severe type of sepsis, then alternate medications which are present that can be used based on the particular source of sepsis, whether it is UTI, pyelonephritis, pneumonia, etc. Okay, so all of this comes into question when we choose the antibiotic. So in general, remember, always we are worried about severe sepsis with septic shock. And because patient has a bloodstream infection, remember ESBL bloodstream infection, drug of choice is carbapenems. Okay. So what does the European guidelines and the IDSA 2024 tell us? We'll look into it in detail. Okay. So if it is cystitis, you can choose your trimethoprim sulfamethoxazole or your fluoroquinolones like Ciplox or Levoflox. Okay, obviously carbapenem is going to be susceptible and you can go ahead and use it, but you can keep this as a reserve drug. Okay, sometimes if it is just a cystitis, you can still use a single dose of aminoglycoside or oral fosfomycin. Oral fosfomycin and single dose aminoglycoside are preferred for ESBL cystitis when the organism which is grown is E. coli only. Okay. Otherwise, if it is non-E. coli cystitis, probably you might have to choose a fluoroquinolone or a carbapenem as a standard regimen for around 5 to 7 days. Okay. So that is the duration of therapy which has been mentioned for gram-negative MDR sepsis. Okay. The next recommendation is again for ESBL pyelonephritis or complicated urinary tract infection. Again, here you can give this patient Septran or levofloxacin or Ciplox. Okay, if at all this patient is unable to receive any of the above said antibiotics, then the drug of choice would definitely be yeah, carbapenems. Okay, so alternatively, you can still use aminoglycoside, but it should be a full treatment and not a single dose. I've already mentioned about severe infections. Drug of choice again here would be meropenem. Coming to AMP-Cs in ESBL, okay, we know AMP-C is a inducible gene. It is a plasmid-mediated resistance. Okay, just recall that part when I spoke to you again. Okay, all the space organisms come there. Okay, so what they say is sometimes cefepime can be used. Okay, so but only thing keep in mind that itself can be an inducer. Okay, so in these cases if you find that this patient has severe sepsis, please go ahead and start the patient on carbapenems. Okay, so this is one thing that you need to look into. Okay, what type of organism came? If it is a space group of organisms, then always think that is an AMC producer. And remember, these AMC producers usually have a higher propensity to induce it to the sister generations. So that is the reason it's better to choose carbapenems in these group of patients as well. Okay, so this is about the management in ESBLs. Okay, so the ESCMID actually is a little way back. Okay, they're still not upgraded, but majority IDSA is the latest one. So if you remember one, I think so it's more than enough. Okay, because ESC again there are certain differences which are seen. Probably we might get confused. I would suggest you guys to remember IDSA because that is one thing which is universally followed. Okay, so most of the places it is more or less the same. So if at all there is one take home point from ESBLs that I want you to take, divide it into two major things. Okay, one is severe infections. Okay, especially when I talk about severe infection, it is bloodstream infection. So drug of choice is carbapenems. The other group is whether it is UTI or pyelonephritis. Okay, so if it is UTI, you can still use your trimethoprim sulfamethoxazole or your fluoroquinolones. Okay, so if it is pyelonephritis, also you can use dimethoprim sulfamethoxazole or fluconazole. I sorry, fluoroquinolones. Okay, so in these cases, for some reason, if you're unable to use the drugs, then again you can choose carbapenems. Okay. Then the last one I was telling you about is AMC inducers. So if you see that you have a space group of organism which is growing, and that space group especially is something like Enterobacter, cloacae complex, etc. So at that particular time, you can still think about use of carbapenems. Okay. So this is about ESBL. Coming to the next group of MDR-GNB, that is your carbapenem-resistant enterobacterales. Okay, so in this, you need to choose the antibiotic based on the type of carbapenem resistance. Okay, so till ESBL, we were very safe. We had our carbapenems present and we were able to give it to the patient. Okay, so we were safe enough. But unfortunately, next we have the next bigger bomb, that is your carbapenem resistant organisms. Okay, in carbapenem resistance organisms, what you need to know is key principle is firstly find out what is the type of resistance. Okay, we all know about the Ambler's classification. Based on that, majorly what we need to know if it is a serine type of a carbapenemase or a metallocarbapenemase. Okay, so the whole thing depends on that, whether there is endium positivity or a oxa positivity. Okay, or both are present. Okay, all of this is something that we need to know. Okay, newer beta lactamase inhibitors are usually the ones which are chosen. Okay, so especially when there are KPC producers, that is Ambler's class A, you can use meropenem, Weber-Bactam, imipenem, Rilibactam, or ceftazidime, avibactam alone. Okay, if at all we have an NDM, WIM, or an IMP, which is given to us based on the Carbar assay or the molecular testing for resistance pattern, then you need to add what? Astrionum, that is your monobactam to the combination of probably ceftazidime avibactam. As of now, in the Indian markets, even we have started getting Astrianum avibactam. Okay, so that can directly be used. Okay, so as an other savior drug, we have one new one. Okay, that is a siderophore antibiotic, that is cefidericol. Okay, so that is your last resort. So try and avoid giving this as a routine drug. Probably we can start with Astrianum avibactam, and then if we find that there is no synergy for this, probably at that particular time we can think about cefidericol. Okay, so I was talking to you about synergy. Okay, so when do we think about doing a combination therapy? Okay, so whenever we have uh, hit a wall. What do I mean by that? You have a patient having NDM organism, OXA48, and then you thought that we can give this patient ceftazidime avibactam plus astrianum or astrianum avibactam, correct? So before giving this, there is a testing called as synergy testing that we have to do, okay, because to say whether this combination of antibiotic will work for that patient or not. Okay, if at all that testing comes as negative, okay, that there is no synergy, then there will be futility of care. Probably that will not be a good choice. At that particular time, we need to think about combination therapy, and whatever we are talking about combination therapy is our last resort. Okay, as of now we don't have great data about it, but definitely we are left with no option. So only combination therapy when we are talking about CRE is a polymyxin based therapy. Either it is polymyxin B, or you can think about the use of colistin. Okay, so we know for urine, colistin is a very good drug of choice. Okay, elsewhere we can use polymyxin. Okay, so this is the role of combination therapy in CRE. Okay, I hope I'm clear. Remember, carbapenem resistant enterobacterials. Firstly, find out what is the resistance pattern, whether it is Ambler's classiae like KPC. If it is only that, go ahead, give ceftazidime avibactam. If it is a metallobeta-lactamase, like your NDM, WIM, and IMP, then you need to start this patient on Astrianum avibactam. If the person has metallobeta-lactamase and your OXA48, then you have to again give Astrianum avibactam or Astrianum plus ceftazidime avibactam. Okay, only OXA48, similar to what we do in Ambler's A, we can just give the patient ceftazidime avibactam. Okay, once you get a patient with metallo-beta-lactamase production, if the synergy for Astrianum avibactam or Astrianum plus ceftazidime avibactam is not present, then probably we might have to think about a combination therapy, which is a polymyxin-based therapy. Okay, so this is about CREs. The newer drugs, if you are talking about CRE management, one drug you can remember is a cererophore antibiotic, that is a cefidericol. Okay, so this is about your CRE. So we finished ESBL, CRE. Okay, so this table you can take a screenshot. Okay, so what do we do for CRE in each of the site of infection? If it is uncomplicated cystitis, you can still go ahead and use trimethoprim sulfamethoxazole, levofloxacin, and nitrofurantoin. Alternatively, you can use a single dose aminoglycoside. Okay, definitely all the other drugs like ceftazidime, avibactam, meropenem, avibactam, all of them come into existence only based on the culture sensitivity report and the type of resistance. Okay, so even in pyelonephritis, similar to uncomplicated cystitis, you can use the same regimen. Okay, only when you feel that this patient has non-urinary CRE, especially with the KPC, okay, you have to think about use of Zavicefta, that is your ceftazidime avibactam or meropenem avibactam. Okay, so the rest of the things is what I've already mentioned earlier: CRE plus NDM, CRE plus OXA48, or CRE NDM plus OXA48. Okay, so remember this. If you take a screenshot of this, I think so it should be enough. Okay, okay. So here you can write it as NDM plus minus OXA48. Okay. So I told you about cefidericol. What do we do about other newer drugs? Okay, we have tetracyclines like tigecycline and eravacycline. Correct? Can we use these drugs for any source of sepsis or any site of sepsis? No. Majorly tetracyclines like tigecycline and eravacycline, the role as per IDSA is only for lung, skin, and soft tissue, intra-abdominal, and osteomyelitic lesions. Okay, Usually, your eravacycline or tetracycline is ineffective for urinary infections and bloodstream infections. Okay, remember tetracyclines. This is a very important viva question. Okay, they will ask you, can I choose eravacycline? No. Can I choose tetracycline? No. Okay, if it is a UTI or a bloodstream infection, you cannot use tetracycline or eravacycline. Okay, so keep this in mind. That's the reason I have kept it as a separate slide. Okay, so please remember, the role of tetracyclines like tetracycline or eravacycline in CRE is only for pulmonary, skin and soft tissue, intra-abdominal and bone. It's a strict no-no for UTI and bloodstream infections. Coming to the next group of organisms, that is your carbapenem resistant Acinetobacter baumannii. Okay, so we all know this is one of the deadliest high priority or critical priority pathogen in the WHO list. Again, what are the options that we have here? What is IDSA telling? That is what I want you to know. Okay, so as of now, based on the 2024 guidelines, high dose ampicillin sulbactam or plain sulbactam is what is being the first choice therapy which they have asked for crab. Okay, if at all we don't have this, then we can go for a polymyxin based therapy, either your polymyxin B or colistin based therapy. Cefidericol, as of now, has shown some promise, especially when there is resistance to all or poor clinical response to sulbactam based therapy. It can be used as an alternate therapy. Okay, so this is based on a recent trial called as the Credible CR trial. Okay, so CRE, you can use cefidericol. Crab, you can use cefidericol. But crab, again, step one, you need to use high dose ampicillin sulbactam. So what is high dose? We'll talk about it. Okay. So I told you it's a sulbactam based therapy. You can either use sulbactam, durlobactam if it is available. If it is not, high dose ampicillin sulbactam is what you need to use. So what is the dose that you need to give? It's a daily dose of 9 grams, okay, of sulbactam, which is supposed to be given to the patient. Okay. So this is the initial treatment approach for MDR Acinetobacter. Okay. So if at all we are using a combination therapy, that is your polymyxin based therapy, what are the things that we can use? Either we can use polymyxin B, minocycline, tetracycline, or cefidericol. Again, for crab, they are telling not to go and use eravacycline. Okay. So cefidericol, whenever we are using, better to use it as a combination therapy, mostly because they do not want resistance to be developed to this particular antibiotic. Okay, so because it's a reserve antibiotic, that is one of the reasons they are telling it to be kept as a combination therapy. Here you can use combination cefidericol polymyxin or cefidericol carbapenems. Okay, you can do any of those combinations. Okay, so as of now, combination therapy is as a last resort in crab as well. Okay, there is no major a trial which has shown that combination therapy is better for crab infections as of now. Okay, so all of this is again based on your antibiotic synergy testing, etc. And a lot of trials have been done to see what is happening with crab infections. Okay, it's not just in India; it's around the world. Okay, coming to the penultimate one, that is Pseudomonas aeruginosa, that is difficult to treat, or carbapenem resistant Pseudomonas aeruginosa. Okay, so newer agents with activity versus resistant to Pseudomonas, what they are using right now is ceftolozane, tazobactam, okay, ceftazidime, avibactam, imipenem, relibactam, or cefidericol. Okay, so the only thing IDSA says is whenever we are choosing these drugs, especially with the BLI, beta-lactam, beta-lactam-based inhibitor combinations, try and use it as an extended infusion. Okay, so especially if the patient is having an altered PKPD, like the patient is having septic shock, the patient is having hypoalbuminemia, the patient is having acute kidney injury. Okay, in all such patients, probably it's better to give this patient the antibiotic as a infusion. Obviously there are other repercussions and other issues that we face, okay, that we might have to think on a case by case scenario. But remember, IDSA says that it's better to give a beta lactam type of an antibiotic as an infusion. Okay, so coming to the gist of how to treat MDR Pseudomonas. Okay, so they say BLBLI is better than carbapenems when it comes to resistant Pseudomonas. Okay, so whenever we are talking about beta lactams, a high dose infusion therapy, usually over 3 hours, is what is recommended. Okay, so in uncomplicated cystitis, you can start ceftazidime avibactam, imipenem relibactam, or ceftalozone tazobactam. In pyelonephritis, also it is the same group of drugs. So that is about your urinary tract. Coming to the non-urinary type of infections, okay, that time you can use ceftazidime avibactam plus aztreonam or cefidericol based on what the resistance pattern that has been detected. Okay, so this is about MDR Pseudomonas based on 2024 IDSA guidelines. Coming to the last group of organisms, that is your Stenotrophomonas, the best available treatment is three for this. Okay, so either you can go with trimethoprim sulfamethoxazole, that is your Septran, that is usually the standard of care, and sometimes there will be resistance seen to trimethoprim sulfamethoxazole as well. In such cases, what they say is you can use levofloxacin. The other alternative drugs for Stenotrophomonas are minocycline and ceftazidime avibactam. Okay, so data is very limited. Okay, only recommendations are based on case reports which have been seen, especially to trimethoprim sulfamethoxazole resistant organisms. So remember, Stenotrophomonas first line is Septran. Alternatives are minocycline, levofloxacin, and Zavicefta. Okay, so coming to the last part of treatment, what is synergy testing? So I was talking about combination therapies. I was talking about multiple resistance patterns, especially when we have NDMs. And when NDM comes and you don't have synergy for that, what do we do? Correct. So that is what we need to understand. So firstly, what is synergy testing? Synergy testing is a laboratory method used to evaluate the combined activity of two or more antimicrobial agents. Okay, against sometimes a resistant organism to see if the effect is greater than the sum of each drug alone. Okay, so they just want to see if 1 plus 1 adds on to 3 or more. Okay, something like that, just a rough estimate. They just want to see if this combination works against that particular MDR sepsis. Okay, so majorly it is useful for MDR or XDR. Okay, so PDRs also you can go ahead and use it. Okay, just that we need to see if the combination therapy breaks the resistance pattern. Okay, so when do we use it, and in which organisms do we use it? We use it in CRE, we use it in crab, use it in difficult to treat Pseudomonas. Okay, so susceptibility options in these organisms are very limited, and that is the reason we do synergy testing for all these organisms. Okay, so what are the synergy tests that we use? One, I told you earlier, polymyxin based therapy or a tetracycline like your tetracycline based regimens. Okay, so usually both of them are tested with drugs like carbapenems, rifampicin, aminoglycosides, and sulbactam. Okay, so you can do a permutation combination and then check. Okay, for this. And how do they do that? Okay, there are multiple ways they do a synergy test. Okay, the most common one is a checkerboard assay. Okay, so what they do in a checkerboard assay is they calculate something called as a fractional inhibitory concentration index, or FICI. Okay, so if at all there is synergy which is present, the FICI value should be low. That means to say the clearance is better. Okay, so less than or equal to zero point 0.5 indicates synergy. If it is between zero point 0.5 and 4, then it is indifference. If it is more than 4, it is antagonism. Probably there is no effect. Okay, so this is one way of doing synergy testing, checkerboard. Okay, remember FICI, that is your fractional inhibitory concentration index. Okay, so serial dilutions of two drugs are used in wells. Okay, so these wells, they see how they are able to achieve clearance. Okay, other ways is time to kill assay, e-strip crossing. Okay, molecular rapid techniques, etc. Okay, so all of these are methods to do synergy testing. Okay, so remember synergy testing for difficult to treat organisms, especially Pseudomonas, CRE, and crab. How do they do it? Usually they use a checkerboard, time to kill assay, e-strip, or molecular methods. Usually, I told you earlier, it is for crab organism CRE, okay, to see whether colistin plus meropenem has some effect, sulbactam colistin for crab, astrinum plus ceftazidime avibactam for MBL, that is your NDM type of resistance, okay. So remember, in vitro synergy is not a guaranteed clinical efficacy. Okay, so usually when you do a synergy testing, if it comes negative, sometimes you should still go ahead and give that drug and see if you have no other options. Okay, sometimes there are other mechanisms by which the drug can act. So at that particular time is where we come with understanding that combination therapy is the only way forward. Okay, we are left with no other option, and out of desperation we are doing that. Okay, so remember, synergy testing is not a gold standard test to give treatment to that person. Most of the sanity testing is a lab based testing, so we do not know what the in vivo conditions are. Okay, so that is one take home point and one of the limitations for synergy testing. Okay, coming to a summary of management of MDR sepsis. Okay, MDR sepsis, firstly, what do we do on an immediate basis? Assess the severity, remove the infected lines, source control, etc., like we do for any case of sepsis. Start the patient on empiric antibiotics based on the local antibiogram with assessment of risk factors. Okay, this is something that we need to write in your exam paper. Then go ahead, do your routine testing like antimicrobial sensitivity testing, followed by resistance pattern, if at all there are any. Then, based on evidence, especially the latest IDSA protocols, you can go ahead and treat this patient. Okay, so remember, probably beta lactam antibiotics better to give it as an infusion in severe septic patients. So that is one way to optimize your PKPD principles. Also mention about therapeutic drug monitoring wherever it is necessary, especially for aminoglycosides, vancomycin, etc. Okay, so whenever you have patients with CRE or CRAM, as of now, IDSA is telling that it's better to isolate these two group of organisms because there is increased risk of transmission. Okay, so this is about management of MDR gram-negative sepsis. So as a take home, I would want you guys to take a screenshot of this. Okay, so most of you would be thinking, what are the other newer antibiotics which are present? What can I give? Correct. So you can take this and use this as a guide to read up and use it as a routine practice as well. I'll be sharing one article after the class today wherein you can read about it as well. Okay, it's one of the articles which was published in January, I think so, in Lancet, if I'm not wrong. Okay, I'll share it with you guys. Okay. So, how to approach an answer? Define and classify what is the problem, error it's present. Mention the patterns of resistance. Outline the general approach to septic patient, like your fluids, source control, culture sensitivity, identification, all the routine sepsis management. Then talk about specific antimicrobial therapy. Mention newer drugs. If you write the dose, excellent. If you can't recall, don't worry. But I would suggest you to please recall. Okay. And if at all there are trials like the Credence trial, which I mentioned earlier about cephedricol, okay, Merino trial, all of this, if you can remember, please remember and write them. Okay. So this is about management of MDR sepsis. Any questions? I'll be happy to answer. Oh, someone scratched on the screen. Okay. Okay. Anshul, I'll look into it. I think so. You asked article on vasculitis per se. Okay. So if you want something in particular, vasculitis or vasculitis is a broad topic. If you want something in particular, please let me know. Otherwise, I'll reach out to you on WhatsApp. Anything else you guys want to ask, or else I'll go to the next topic. Okay. So, continuing with the next topic and the last topic in sepsis, that is fluid therapy and sepsis. Okay, I don't know how questions can be asked in this. I have done this class in the regular group as well. Okay, what I'm anticipating is previously they had asked about ROSE concept. Okay, so that is one place where I thought they might ask. Then they can ask you critically analyze about fluid therapy in sepsis itself. Okay, so therein, how will you approach this answer is what I want you to go through in this particular question. So, what is the aim in fluid therapy in sepsis? It is targeted intravascular administration of fluids, or it can also be removal of fluid. It is majorly aimed at restoration of tissue perfusion, oxygen delivery, and organ function, wherein you are looking at avoiding a catastrophic event like volume overload. Okay, so that is the main aim of fluid therapy in sepsis. Okay, so what is the pathophysiology? We all think sepsis is a state of hypovolemia. Okay, so the main important thing is sepsis is a state of relative hypovolemia initially. Okay, only when we do not treat that appropriately that it goes to a spiral of a vicious cycle of shock. Okay, so that is what we need to offset. It is not necessary that all septic patients are hypovolemic. No, probably we might have to assess their status and then take a call. Okay, so the pathophysiology usually would be like initially there will be a state of vasodilation caused because of inflammatory markers and release of nitric oxide. Majorly because of inflammatory markers, there will be endothelial damage, there will be capillary leak, and extravasation of fluid into the interstitial space. Okay, and because there is extravasation of fluid into the interstitial space, there will be decreased intravascular volume that leads to relative hypovolemia initially. And because of decreased intravascular volume, there will be microcirculatory dysfunction leading to organ impairments or there'll be organ damage. Okay, so this is usually what happens in sepsis. Okay, so sepsis shock pathology, you know, it's a toxin driven systemic inflammation leading to endothelial activation, vasodilation, glycocalyx degradation. Okay, and thereby causing relative or absolute intravascular hypovolemia. Okay, so this causes decreased preload, cardiac output, and microcirculatory flow, which has a varied effects on the total body water. Okay, so if at all we do an overzealous treatment at this particular stage, probably it can lead to detrimental effects of fluid therapy like interstitial edema, worsening oxygen saturation, impaired organ function, okay, compartment syndrome, etc. Okay, so these are the issues which we face with septic shock or sepsis fluid management. Okay, so remember that fluid is both a therapy and a potential toxin if it is misused. So, what is the goal of fluid therapy in sepsis? It's to restore adequate preload and cardiac output. It is to improve tissue perfusion and oxygen delivery. It is to correct metabolic acidosis and lactate clearance and to support organ function, especially when there is septic shock. Okay, always remember fluid and sepsis is not only with patients with septic shock. Okay, most of the times patient will come in just with sepsis, there will not be any shock associated. Shock develops over a period of time. Okay, that is what I want you to understand. So what do we do initially? So imagine that this patient has come to you and we are giving fluids. How do we do that? We need to assess the patient. So if at all a question is asked about how do we manage fluid therapy, we have to start with firstly treat a fluid like a drug. Okay, and then you can tell that there is state of relative hypovolemia initially, then it can progress into septic shock. If you write these 2 points as an introduction to your paper, it's more than enough. Then you write what is the goals of fluid therapy, that is restoration, improvement, correction, and support. Okay, so if you remember this, that should be majorly about your initial part of your answer. Then write about assessment of fluid status. Okay, and then when we have to start fluids. Okay, how do we do the assessment? Firstly, we see for the windows of perfusion. Okay, like your mental status, capillary refill, peripheral perfusion, urine output. Okay, and your vitals like heart rate and blood pressure. Then we look at the blood pressure targets, whether the map is more than 65 mm of Hg, that is their initial goal, and whether that map is having an adequate urine output of more than 0.5 ml per kg or not. And at this particular time, if at all there is hypovolemia based on your dynamic tests of fluid responsiveness, probably you can give fluid therapy to this patient. Okay, so this is a stepwise approach to how we assess volume status in a patient with sepsis or sepsis with septic shock. Okay, so start with clinical signs, define your targets, use dynamic tests of fluid responsiveness, and write about bedside adjunctive tools like your ultrasound, okay, or your echo. Okay, so this is what you need to write about assessment of volume status and need for fluids in patients for sepsis with septic shock or fluid therapy in sepsis. Coming to fluid initial resuscitation, we all know SSG 2021, they say 30 ml per kg within the first 3 hours. Remember, it's not a rigid rule. Why is it not a rigid rule? That is one of the major reasons why it got actually a downgraded recommendation. Okay, I will talk to you about it later on. By saying that, I'm not telling you not to give 30 ml. What I'm trying to tell is Start the patient on an initial 30 ml per kg, but please always go ahead and do an hourly assessment of fluid responsiveness. If you feel that your map target has been achieved, the lactate has been cleared, or any other hemodynamic abnormality has been corrected, probably you can stop or reduce the fluids at that particular time. Okay, it need not be that you have to give all the 30 ml per kg in the first 3 hours. Okay, that is what we need to understand. That is the reason it is not a rigid rule. Okay, why is it so? I'll tell you later. Okay, that is because there was no mortality benefit which was seen. Okay, after the EGDT trial, EGDT trial was the one thing which they all focused on giving 30 ml per kg. Okay, following that, Arise, Process, and Promise went ahead, used the same protocol to see, and what they found out was there is no difference in mortality in both the groups. Okay, wherein they use a lesser fluid volume as compared to 30 ml per kg. Okay, so that is one way they came to an understanding that there need not be a rigid protocol telling that all patients with sepsis require 30 ml per kg in first 3 hours. So that is one of the reasons this recommendation was downgraded in the 2021 update of SSG guidelines as compared to 2016 guidelines. Okay. So once if you have understood 30 ml per kg should be given in the first 3 hours after assessment of fluid responsiveness in a patient with sepsis, then what do we do? Okay, so this is what we have done till now, right? So we have seen what are the issues, we have examined the patient, we have understood that this patient is having fluid deficit, gone ahead and given, and if the patient is responding, there is adequacy of restoration of organ perfusion, etc. Well and good. If it is inadequate, probably we need to choose vasoactive agents. What are the resuscitation targets we are looking? Urine output, MAP, SCVO2, normalization of lactates. Urine output and MAP is majorly what we need to look at. Normalization of lactate is what lactate clearance is what you need to remember. Okay, so if you remember, more than 30% is excellent, less than 10 is not good. Okay, so that is one thing you need to recall whenever you're talking about lactate clearance in patients with sepsis with septic shock. Next, we have addressed the volume of fluid. What is the type of fluid is the next question. Okay, so in the next part of your answer, write about what is the type of fluid. Okay, remember right now we have no ambiguity telling that crystalloids are the fluid of choice in patients with hypovolemia and sepsis. Okay, we all know there's a lot of evidence telling that colloids are harmful. Okay, so why again is crystalloids very much safe? No, probably overzealous over treatment with crystalloids again can cause acute kidney injury and hyperchloremia and hyperchloremic metabolic acidosis. So remember that is one of the drawbacks for balanced crystalloids. So first answer would be amount of fluid. Second, type of fluid, balanced crystalloids over colloids. Again, colloids, higher mortality, risk of AKI present. Crystalloids, increased crystalloids over balanced crystalloids can cause uh, risk of hyperchloremic metabolic acidosis and AKI. Just remember this. Okay. So coming to the evidence for type of fluid, what is the evidence? Your salt ed, your smart trials, your basic trials, okay, they did not come to an understanding that balanced crystalloids over zero point 0.9 saline is superior or not. Only thing what they came to a consensus was the incidence of make 30 and make 90, that is major adverse kidney events, okay, was lesser in balanced crystalloids as compared to normal saline. That is the first point and first evidence that you have to write about type of fluid. The next evidence that you guys have to mention that starches, especially the colloids, okay, there is harmful effect based on the YSEP trial, the Scandinavian 6S trial, and the CHEST trial, okay, and that is the reason it is contraindicated. Then there will be talk about albumin, okay, so we cannot leave albumin. Majorly, they will focus on this. Albios trial did not show any mortality benefits. Only thing is, even in SST guidelines, they say if there is a large volume resuscitation which is happening, okay, then you can think about using albumin. Okay, what exactly is the percentage of albumin? Whether it is 20% albumin, 5% or 4.5% albumin, that needs to be discussed. Okay, so remember balanced crystalloids is the first choice as compared to colloids in the type of fluids in sepsis management. Okay. Coming to albumin in fluid therapy, remember I told you earlier 4 to 5% albumin and 20% albumin. There is a huge difference. Okay. So there is always a problem with these fluids. What is the problem? 4 to 5% albumin is usually safe for septic shock patients, given the fact that they do not have any other issues like traumatic brain injury. Why? On the whole, if you see, 4 to 5% albumin is usually a hypo or a isooncotic fluid. Okay, so they roughly fall between 270 to 280 milliosmoles. Okay, so that is one of the reasons they say that is a hypooncotic fluid, and there will be risk of worsening the traumatic brain injury whenever we give this concentration of albumin to patients with TBI. So in any other patient, probably it is better to start with 20% albumin so that we maintain the intravascular volume, colloid oncotic pressure, and also maintain effective organ perfusion. Okay, so this is about albumin. Okay, so if at all a question is asked about mortality benefit, again we do not see anything as of now. Okay, so that is about it. Having said that, there are a lot of trials which have been done. Okay, so there is a recent trial called as the ARIS trial, which is still awaited. ARIS trial is looking at achieving a very high target. Okay, they're trying to get at least 3 grams of albumin in the period of stay in the ICU. So probably it is an overzealous cost effectiveness, etc., will come into picture again. So as of now, there is no mortality benefit based on a lot of trials like a SAFE trial, Alveus trial, EARSS, RASP, and the meta-analysis which was given by Cochrane in 2018. Okay, so take-home point from albumin is can be used in patients requiring larger volumes, can be used in patients with non-TBI type of sepsis. If it is TBI, please do not use 4 to 5% at that particular time. Probably it's better to use 20% albumin. What is the advantage of albumin? One, it maintains the effective cortic pressure, intravascular volume is maintained, and probably organ perfusion is better, making eventualities or complications like AKI reduce. Okay, this is about albumin as a fluid. Okay, so we talked about volume of fluid, type of fluid. Okay, now we come about the next part of fluid therapy in sepsis, that is protocols. So earlier on, we started with 30 ml per kg. If the patient is responding well and good, probably you can do your dynamic assessment and then give this patient fluid boluses whenever it is necessary. Probably you can do your mini fluid challenge or your small boluses up to 250 or 500 ml. That depends on institution. Okay, so whenever you're giving a fluid challenge, it has to be following all the norms, and better to use dynamic indices as compared to static indices. Okay, whenever we feel that despite fluid therapy, you're unable to reach the targets of resuscitation like MAP, urine output, lactate clearance, sensorium, etc., probably at that time we need to start vasopressors. They say earlier vasopressors is better, and I will discuss why early vasopressors are better. Okay, so firstly, it will prevent fluid overload and prevent you from overzealously loading the patient with fluids. Because if we load the patient excessively with fluid, it can hamper organ perfusion. So, earlier choice of vasopressors can improve organ perfusion, and it can restore the MAP. And when restoration of MAP is achieved, end organ perfusion will be better. So capillary leak, which is usually seen in the early stages of septic shock, that would also be reduced by early use of vasopressors. Ultimately, the whole thing is organ protection. Okay, so sequestration would be reduced, unnecessary overloading would be prevented, and organ protection would happen. This is the rationale for using early vasopressors in fluid therapy in sepsis. Okay, so this is actually based on a lot of trials. Remember Vanish trial? It didn't focus on this, but that is what they actually found out. Okay, early session within 6 hours showed trend towards benefit. Okay, so this cannot be taken as the primary objective, but this was what was an observation. Okay, which they did in Vanish trial. Similar observations were made in Andromen and Sensible as well. Okay, so best way is to start it within 1 hour if it is feasible. But obviously, we are still doing our SSG guidelines up to 3 hours. Probably if your patient is a patient with chronic kidney disease, ischemic heart disease, etc., wherein you cannot give overzealous fluid therapy, probably in them you can start it within 1 hour. Other patients, especially a young patient, start with fluid resuscitation, check for volume responsiveness, and the best thing is to start inotropes less than 6 hours. Okay, by doing so, they have said that there will be decreased organ defects or multi-organ failure would be avoided, and lesser length of hospitalization and requirement of fluids. Okay, so usually 0 to 3 hours fluids, 3 to 24 hours stabilize this patient, start the patient on inotropes, and 20 to 24, I mean, in the 24 hours and beyond, you might have to de-escalate the patient. So this is basically how you can go about a protocolized approach for fluid therapy in sepsis. Okay. So, first line, according to SSG, NORAD is the first treatment of choice. You know, the predominant action is on the alpha 1 receptor. Okay, it also has an additional beta 1 agonist activity. Okay, second line, we have to use vasopressin. Again, it is based on the SSG guidelines. When do we start vasopressin? Usually, when we are not able to achieve a MAP target of more than 65 mm of Hg, when we are giving a NORAD of more than 0.25 to zero point 0.5 microgram per kg per minute. Okay, you have to remember this, 0.25 to zero point 0.5 microgram per kg per minute. Okay, this is the cutoff for adding the second line of vasopressor, that is your vasopressin. Okay, so what is the target? If you're asked, the thing is, uh, that is your 65 mm of Hg. How did we come? That is based on two trials. One trial, if you remember, is more than good. That is your sepsis spam trial. The other one is called as ovation. If you remember, is good. Otherwise, no problem. So till now, we're talking about sepsis, and in the later slides, you looked at patients not responding to fluid therapy requiring inotropes. So whenever they go into such state, as per definition, it will be converted as septic shock, right? So what do we do in patients with septic shock? In patients with septic shock, we need to think about EROS concept. Okay, so if a question is asked about what is EROS, you need to write this slide. Okay, if you take a screenshot, it's good enough. What is EROS? It is a systematic approach to management of septic shock. It involves early recognition, resuscitation, organ support, and source control. Okay. In early recognition, what do we do? We have history and clinical examination, point of care ultrasonography, appropriate imaging, and microbial testing. In resuscitation, timely initiation of fluids, inotropes, and transfusion if at all it's necessary. In organ support, you need to look for timely interventions like ventilation, renal replacement therapy, and in worst case scenario, even your extracorporeal support. In the meanwhile, when you're doing your ERO, you have to localize the source of sepsis and treat it appropriately. Whether a source control is recognized, firstly, the source is recognized and control should be optimized at the earliest. Okay, this is about ERO's concept of management of septic shock. Coming to the next part of fluid therapy or fluid management in sepsis, this is one question they've asked you previously as well. That is your ROSE concept. Okay, so what is ROSE concept? We know overzealous treatment with fluids in sepsis leads to volume overload states, and volume overload can cause fluid sequestration, back pressure related issues, and it can lead to a vicious cycle causing visceral swelling, interstitial edema, intra-abdominal hypertension, mesenteric congestion, and it just sets in a cascade of or a vicious cycle leading to multi-organ failure, and ultimately it can cause death. Okay, so to prevent this, they proposed a protocol called as the ROSE protocol. ROSE is an acronym which stands for resuscitation, optimization, stabilization, and evacuation. Okay, so what it says is in the x-axis you have the time, in the y-axis you have the cumulative balance. The resuscitative phase is usually between minutes to hours. Okay, the optimization has to be done between hours to the first 3 days. Okay, here optimization is of hemodynamics and source control both. Okay, but majorly in ROSE we are looking at hemodynamics, especially fluid therapy. Then after the 3 days up to probably a week, we have the stage of stabilization, and usually after 1 week is the stage of evacuation or de-escalation. Okay, so this is mostly what is ROS. Okay, so remember, resuscitation is in minutes to hours, optimization hours to a 1 day, stabilization is between 3 days to a week, and after 1 week is evacuation or de-escalation. Okay, so we'll go look at rows in an individual format. Okay, so remember, in the initial phase, I want you to look at both the things. Okay, so look at the graph here, and also look at each things, and please stay with me when I'm discussing the graph. Okay, we should know firstly one thing. Okay, so I'll add one more slide here so that we'll discuss that together. Okay, so sepsis with septic shock, when you are talking about septic shock, it is again going to have two phases called as the ebb phase and the flow phase, similar to what we see in Burns shock. Okay, initially there will be a hypometabolic ebb phase followed by a hypermetabolic flow phase. Okay, so when I'm talking about hypometabolic, hypermetabolic, it changes. Okay, when I talk about hypometabolic, it does not mean that it is not hyperdynamic. It can be hyperdynamic. Okay, there was a confusion which one of the candidates recently asked me. Okay, so even I had to look in much deeper. So remember, take home points: any shock will have two types of phases. One is, the first phase is the ebb phase, it follows the flow phase. Ebb phase hypermetabolic, flow phase hypermetabolic. Okay, so in Rose concept, in R stands for resuscitation. Here we have to be very free in giving fluids. Okay, so what they tell is early adequate fluid management, that is what is EAFM. Okay, so in early adequate fluid management, what is the volume of fluid that we give? That is roughly around 30 ml per kg per hour. Okay, after giving this, you can still continue boluses of 4 ml per kg, which can be given at 5 to 10 minute interval to reach a target of more than 65 mm of Hg. So what do we do this based on? What the triggers for giving fluids would be a positive, PPV, PLR test being positive, lactates getting elevated, your IVC collapsibility index being more than 50%, so on and so forth. So there are triggers that we need to look into along with your map target, and then you have to start early adequate fluid management in R, that is your resuscitative phase of shock. Okay, once this has happened, then we go into stage of optimization. So I told you this is minutes, then we come into hours. Okay, that is your your optimization phase, which focuses mainly on maintenance fluids. Okay, majorly we have to avoid fluid creep like we saw in Burns as well. Okay, so the aim is to achieve a neutral balance between the day 1 and day 3. Okay, so here what do we have to see? Again, you have to make sure that the map target is normalized, PLR is always negative, lactate is always maintained less than 2. Okay, so whenever there is some amount of volume overload which is happening, we need to de-resuscitate at that particular time. Okay, or else you have to maintain the fluid. Okay, so that is why here you can see, here it's escalation, here it is de-escalation also. De-escalation is different as compared to de-resuscitation. Okay, so in resuscitation you be Pindas. You can give 30 ml per kg per hour. After that, do a fluid challenge, give 4 ml per kg every 5 to 10 minutes based on your test of fluid responsiveness. In optimization phase, you need to think about all of this. Okay, that is, you need to think about maintenance, keeping these targets at the optimal level. Coming to the next stage, that is your stabilization phase. Usually, in optimization and stabilization, you see this LCFM. Okay, what does LCFM stands for? It is late conservative fluid management. Okay, so in late conservative fluid management, majorly what we are looking at is we do not want to give excessive fluid. Okay, because there is always a risk of ischemia reperfusion injury which it can happen at this particular time. Okay, so this is what is written here. Okay, that is your second hit. There are four hits. Okay, whenever you have this graph is a little complicated, so I have to explain each thing. Okay, just keep a watch on that. Okay, so in this phase, when we are talking about late conservative fluid management, we are conservative in giving fluids because we do not want any ischemia reperfusion injury from happening. Okay, that is the main focus of optimization and stabilization phase. Having said that, we also have to keep a close watch on the targets. Okay, so always you just can remember MAP, lactate, IVC. Okay, along with this, if you can remember PPV and SVV, it is good enough. Okay, so the only thing is if you can write this throughout, probably that is good enough. Okay, in this especially stabilization and evacuation phase, you can talk about your Vexus score also. Okay, so in this when you're talking about the evacuation phase, you can tell that high vexus initiates the phase of evacuation, wherein you will start removing excessive fluid if at all it is present. So, in evacuation phase, okay, so what we usually do is late goal directed fluid removal. Okay, so that is what is written as LGFR here. Okay, usually it starts between days to weeks, so roughly it is after 4 to 5 days itself you can start de-resuscitating the patient. Okay, so this is about ROSE. Okay, so you see something called as SAVE, right? SAVE is nothing but an acronym for uh, sepsis guided volume evacuation. Okay, sepsis assessment and volume evacuation. Okay, so if at all we remove excessive fluids, then it also causes problems. Okay, so that again can cause the fourth hit, that can cause risk of hypoperfusion. Okay, so remember, in individual terms, I'll just revise this part. Okay, so x-axis, y-axis. X-axis is time, y-axis is volume status. Initially, in resuscitation, bindas, you can give 30 ml per kg, followed by 4 ml per kg every 5 to 10 minutes. Early adequate fluid management. Optimization phase, you have to maintain the trigger targets. Okay, so there should not be any fluid responsiveness that is seen. Okay, I mean, there should be optimization of fluid targets. Okay, so your PRR should be negative and lactate should be normal in optimization. Next, we have stabilization, wherein we have late conservative fluid management. And finally, we have evacuation, that is late goal directed fluid removal. Okay, so these are the four parts of ROSE. Okay, so remember, R is between minutes to hours. Okay, O is between hours to days. S is days to weeks. Okay, and E is after 1 week. Okay, so we need to get all of this within 1 week of hospitalization. Okay, so if at all these are not done properly, then there can be a lot of detrimental effects which can happen in the initial phase. That is the initial hit. If you don't treat properly, you see this image and this image, you'll understand it together. Okay, you have to understand it as a whole. So the first image shows what you do for resuscitation, and if you don't do properly, what will happen. So if the patient comes to you at time 0, if you treat the patient properly, then the risk of organ failure comes down. Okay, so you are treating the initial insult. If you treat overzealously this patient, again, then also there is a risk of organ failure developing. That is what is the upstroke which you see in organ failure in the graph below. Okay, so that is why I was talking to you about de-escalation, that is late conservative fluid management. So once you start seeing there is some amount of uh, venous overload or vascular overload which is coming there, you have to start de-resuscitating the patient. Once you start achieving the de-resuscitation, again you start seeing that organ failure starts coming down. Okay, so that will be your third hit. So if the third hit will happen when you overzealously continue treating the patient. So first, without treating, you will have organ failure. Starting treating, because it's returning to normalcy, there might be ischemia reperfusion injury or global increased permeability syndrome. Okay, global increased permeability syndrome is because still there are some leaky capillaries present, and that is one thing which can cause damage to the organs. Later on, you have the last phase. Okay, the last phase, again, if you see here, again you're seeing an upstroke towards organ failure. Why is that present? It is majorly present because if you still continue evacuation phase, that is continue the patient on de-resuscitation strategy like starving the patient of not giving fluids or giving excessive diuretic therapy or renal replacement therapy, the patient can still again develop organ failure. Okay, so this is the four hit rose concept as a whole. Okay, so it does not end with resuscitation, optimization, stabilization, evacuation alone. You need to understand the hits also and talk about organ failure and parts of fluid management. Hope I'm clear. Okay. I know it's a little complicated. If you feel that that previous thing was very complicated, you cannot remember much, just remember this slide. Okay, that is why I put this slide. So remember, in resuscitation phase, you can do early adequate fluid management with 30 ml per kg, followed by small boluses of 4 ml per kg. If you're not reaching the target, start early noradrenaline, especially when the diastolic BP is less than 50 mm of Hg or a diastolic shock index of more than 3. In optimization phase, you have to again consider about conservative fluid management. Okay, check for fluid balances. If at all fluid is necessary, it should be as boluses. At this time, if you feel there's increased requirement of crystalloids, you can use fluids like albumin. In stabilization phase, again watch for fluid creep because this patient is at an increased risk of developing global increased permeability syndrome or leak syndrome. Okay, so in these patients, you have to start de-resuscitation or evacuation and then keep a check on cumulative fluid balance. It can either be with diuretics, ultrafiltration, or with the need of albumin. Okay, but only thing is maintain euvolemia in this patient. Don't again dehydrate the patient. Okay, so this is about Rose concept. Okay. So now we have come to an understanding of Eros, Rose concept in fluid therapy. Then the last thing is what about liberal versus conservative fluids. Okay. So Rose, we were all talking about early liberal or early adequate fluid management followed by late conservative fluid management. Has there been any major mortality benefit between the two? Unlikely. Okay. So there are a lot of studies which were done. Okay. Starting from the EGDT, Feast, Arise, SSP, the latest one being the Clovers trial in 2023. Okay, currently there is no consensus telling that restrictive group is better or superior over liberal fluid resuscitation group. But having said that, it is always better to do a dynamic fluid assessment and maintain euvolemia as much as possible. So why do we have to do this? Why do we have to maintain euvolemia, avoid overzealous fluid resuscitation? That is because there are adverse effects of fluid overload. What are they? Tissue edema, pulmonary complications, cardiovascular effects, renal impact, coagulation defects, and gastrointestinal hepatic and cerebral edema also. So these are the effects or complications of overzealous fluid therapy. Okay, if they ask you fluid therapy in general, also you need to write about complications of fluid therapy. In this, you can write it as an individual organ-based approach. Okay, so remember in tissue edema, it causes impaired oxygen dissociation, pulmonary complications like pulmonary edema, worst case scenario, ARDS. Cardiovascular definitely puts a strain on the heart. Okay, your right ventricular strain can increase. It hampers the demand supply mismatch. Okay, similarly dilutional coagulopathy can happen, hypothermia can worsen. All of this is the issue with the coagulation factors. Venous back pressure can cause acute kidney injury again. Okay, your renal resistive index, etc., comes into picture, especially when you're using tools like Vexis. Okay, Vexis, RRI, all of them can be used as a tool to look for the development of acute kidney injury in patients with fluid overzealous fluid management. Okay, so this is about complications of fluid overload. So to avoid complications of fluid overload, you have to use fluid stewardship. Okay, so fluid stewardship is similar to your drug stewardship. What I told you earlier, fluid is again a drug. Okay, treat it with the four Ds. Okay, that is your drug. What are we using? What is the type of crystalloid? If you're using a colloid, for which patient we are using and when are we using? All of that has to be questioned. How much we are using, that is the dose. how long are we using, is the patient is in resuscitative phase, optimization phase, stabilization phase, or the evacuation phase. So all of this comes into questioning. And finally, whenever we have achieved our targets, we need to think about de-escalation. Okay, if you can take this screenshot, I think so you'll understand it as a whole. Okay, here this fluid stewardship, when you're looking at it, it looks into Rose concept as well. If you see, okay, there are 4 questions, there are 4 indications, and 4 stages and 4 hits. They are also mentioned here. If you can read this slide, I think so you'll be able to understand. Remember, Rose concept was actually given by Malbrain, Manu Malbrain. Okay, so it was him who started it in, I think so, 2014 and later on. Okay, just remember this. So if at all the question is asked, to summarize, starts with initial resuscitation, balanced crystalloids over colloids. Dynamic measures should be taken. Early vasopressors therapy, Vanish trial, sensor trial, Andromeda shock trial. Okay, that is the thing. Resuscitation based on the Rose concept. Albumin only role is whenever there's excessive fluid which is required. Okay, always keep a watch, because if you don't keep a watch, the patient can end up having fluid overload state. That is your fluid accumulation syndrome or global increased permeability syndrome. Okay, so this is a gist of what happens if excessive overzealous fluid therapy is done. Okay, so it can cause or cerebral edema, pulmonary edema, ARDS, liver congestion, acute kidney injury, myocardial ischemia, gut congestion, etc. Okay, so this is about fluid therapy. So treat it as a drug. Okay, that is the most important take home point. Thank you. So I know it was quite an extensive talk, but what I want you to remember here is, first, write about the aim, okay? Then talk about the pathophysiology and the goals. Then assessment, you can write this, okay? History, examination, and lab test, and what are the targets. Initially, if you resuscitate, if the patient gets these targets, you can stop the fluids. If it is inadequate, probably you might have to start vasopressors. Okay. Again, write one a small para on type of fluid. Okay. And what is the choice and what are the trials? Again, albumin, no major benefit as of now in terms of mortality. Probably it reduces the risk of AKI. Okay, protocolized approach is what you want. Early vasopressor therapy. When you are talking about protocolized therapy, you can talk about the Rose concept. Okay, remember Rose: 4 hits, 4 stages. Early adequate fluid management, late conservative, late goal directed fluid removal, and then volume evacuation. Okay, so this is what you need to remember. 4 hits. Remember, organ damage can happen in all the stages. It just depends on how we are resuscitating. Okay, so this is about the Rose concept. No major evidence based on liberal versus conservative. Fluid overload. When you're talking about fluid therapy, don't forget to write the complications of fluid overload. Then talk about fluid stewardship. If the question itself is fluid stewardship, probably if you write this slide, it's more than enough. Okay. So, what are the worst case complications? They might ask you questions like, what is global increased permeability syndrome or fluid accumulation syndrome? Okay. So, it's just by overzealous treatment in stage 3 of Rose concept, that is your stabilization phase. Okay, because if you have continued overzealously treating the patient can end up in something called as GIPS. Okay, so this is about fluid therapy. Any questions, please ask, or else you can leave it in the chat box. Okay, thank you.